We've arrived at what was once the beacon for teenage angst everywhere, that tattered t shirt temple. You know it as your favorite stop at the mall. Besides the food court, of course. Ectopic. Interesting, since this sketch is going to cover one of the most bread and butter OBGYN topics we can think of, ectopic pregnancies. This is a super important topic to know everything about, so listen carefully as these power chords play. Makes me want to put unnecessary safety pins in all my clothes. Anyways, the definition of an ectopic pregnancy is any pregnancy that implants in an extrauterine space. Basically, it's a pregnancy in the wrong location. These are non-viable pregnancies that constitute about 2% of all pregnancies that are conceived. In addition to being abnormal, all ectopics can potentially rupture, which is a life-threatening situation. The most common place for an ectopic pregnancy to implant is the fallopian tube. To refresh your memory, the fallopian tube has 4 sections. Going from most proximal, which is the part closest to the uterus, to most distal, they are the isthmus, ampulla, infundibulum, and fimbriae. Around 70% of ectopic pregnancies implant in the ampulla, which is the middle section of the tube, highlighted on this fallopian tube archway in red. In addition to the fallopian tube, other places ectopics are normally found are in the cervix, uterine cornua, also called an interstitial pregnancy, and in prior uterine C-section scars. As you'll soon see, much of the workup of a suspected ectopic is trying to prove there's an intrauterine, aka normal, pregnancy. The general idea is, if a woman has a positive beta HCG and you're able to diagnose an intrauterine pregnancy on ultrasound, then you've ruled out the possibility of an ectopic. While this is the case the overwhelming majority of the time, there is a very rare situation wherein a woman can have both an intrauterine pregnancy and an ectopic pregnancy. This is called a heterotopic pregnancy and is more common in women who have had IVF, though even within this population, a heterotopic pregnancy is still very rare. Much more common and more concerning are ruptured ectopic pregnancies. This happens because as the ectopic pregnancy develops and gets larger, it starts to outgrow the very confined space it usually finds itself in, such as the fallopian tube. When this happens, the structure ruptures and causes a tremendous amount of internal bleeding. This is a medical emergency, as this bleeding can happen very fast and patients can decompensate in a matter of moments. In fact, ruptured ectopics cause the majority of first trimester maternal deaths. All ectopic pregnancies have the potential to rupture, which, again, is another reason it's so important to catch them before they do. Now, moving on to our patient. Any sexually active female of reproductive age can have an ectopic pregnancy. If she hasn't gone through menopause, she can get pregnant. The most common patient presentation for an ectopic pregnancy is vaginal bleeding and abdominal pain. The vaginal bleeding can range anywhere from light spotting to heavier bleeding. It's even possible to have no vaginal bleeding. In general, light bleeding is the most common bleeding pattern when a patient has an ectopic pregnancy. The other hallmark symptom of an ectopic pregnancy is abdominal pain, specifically lower abdominal or pelvic pain. This pain may be unilateral or bilateral, or like vaginal bleeding, some patients may have none at all. Note if the patient's pain is getting worse, as this may be a sign of an impending or already ruptured ectopic. In addition to vaginal bleeding and abdominal pain, patients who don't know that they're pregnant at the time of presentation may note a prolonged amenorrhea for a number of weeks prior to their current symptoms. Typically, ectopics will declare themselves 6 to 8 weeks after the patient's last menstrual period. That's around 2 months, so this spot-free mannequin is wearing 2 full moon earrings. In terms of your patient's past medical history, look for the following things. If your patient has had a history of an ectopic pregnancy in the past, this puts her at a much higher risk of having another ectopic pregnancy. If she's had a history of one ectopic, her risk of another one is approximately 10%. If she's had 2 ectopics, her risk is 25%. Another well-known risk factor is a history of pelvic inflammatory disease, also known as PID. PID is caused by a gonorrheal or chlamydial infection, and if left untreated, can lead to scarring in the tubes. Looks like the reason this woman in the stained one sweatshirt is having some abdominal pain may be that she ate the clam pasta from that new Venetian gondola restaurant in the food court. Never eat shellfish at the mall, kids. Sticking with tubal abnormalities, women with a history of infertility due to a tubal factor, such as a scar or stricture in the fallopian tube, which we'll remind you of with this scratchy graffiti on our fallopian tube archway, are also at a higher risk of developing an ectopic. Many of these women undergo assisted reproductive technology to get pregnant, and unfortunately, this doesn't mitigate their risk of an ectopic. In fact, it makes it higher. In vitro fertilization, or IVF, is another known risk factor, and the risk increases with the number of embryos transferred. Intrauterine devices, a type of long-term contraception, are, in a way, another risk factor for ectopic pregnancies. We say in a way because overall, if a patient has an IUD in place, she is much less likely to get pregnant, as these devices are 99% effective. However, if the device fails to impede conception, 50% of these pregnancies that are conceived with an IUD in place are ectopic pregnancies. In terms of past surgical history, a history of tubal sterilization, either by salpingectomy or tubal ligation, also interferes with the patient's tubes, therefore putting her at increased risk for ectopic pregnancies if the surgery fails. Finally, when taking the social history, ask her about smoking history and the number of cigarettes she smokes per day. The risk for ectopic increases with the number of cigarettes smoked. Now that we've taken a thorough history, it's time to move on to our objective findings. Vitals are a very important part of the workup for suspected ectopic pregnancies. Patients whose ectopic pregnancies have not ruptured yet will typically be hemodynamically stable. However, if you see any signs of hemodynamic instability, such as tachycardia and hypotension, you'll want to move quickly, as many of these patients could be bleeding internally from a ruptured ectopic. We've drawn in this falling skater with her raised heart watch on top of the ruptured strap uterus backpack to remind you of the important association between hemodynamic instability and ruptured ectopics. Also, keep in mind that young, healthy patients often don't show signs of hemodynamic instability until they've already lost quite a bit of blood, so if her vitals are changing, it's time to move fast. In terms of physical exam, the two components to pay the most attention to are the abdominal and pelvic exam. On abdominal exam, you may note some tenderness to palpation in the lower quadrants, right where this fallen skater seems to be feeling it. However, if you see any signs of an acute abdomen, such as extreme tenderness to palpation, rigidity, rebound tenderness, symbolized by her rebounding helmet, and guarding, this is an indication to go to emergency surgery, as these are signs of internal bleeding. Conversely, all those signs of an acute abdomen are going to be things you want to make sure your patient doesn't have. So it's important to assess for them during every single abdominal exam you do. The pelvic exam is another crucial component of your physical exam. As you know, it consists of two components, the bimanual exam and the speculum exam. On bimanual exam, symbolized by these two purple gloves, you'll note adnexal tenderness, and you may or may not also note adnexal fullness. When palpating the size of the uterus, it may feel slightly enlarged compared to a non-gravid uterus because hormones secreted by the ectopic pregnancy will still cause the uterus to enlarge a bit. However, the uterus will still measure size smaller than dates because this isn't a normal pregnancy. In terms of the speculum exam, the main thing you want to look out for is to see if the cervix is dilated with any tissue in the vagina, which may be a sign that this is an aborting intrauterine pregnancy rather than an ectopic. If it is an ectopic pregnancy, the cervix is usually closed. Now on to labs. The first lab you must get is a beta-HCG. Initially, you want to know, is she pregnant or not pregnant? If the answer is yes, then note the quantitative amount of beta-HCG. In addition to the beta-HCG, you should also get a CBC for baseline hemoglobin and hematocrit, and also assess for any evidence of anemia that could be due to a concealed hemorrhage. Though it's not always a part of the typical ectopic workup, some providers will draw a progesterone level. A progesterone level below 10 nanograms per milliliter is evidence towards an abnormal pregnancy. Again, this is not a routine test and should be used as just another piece of evidence to support or refute a diagnosis of an ectopic pregnancy. Equally important as the beta-HCG is the transvaginal ultrasound, symbolized by this TVUS detector wand. The transvaginal ultrasound can show you if there's evidence of an intrauterine pregnancy or if there isn't. In ectopic pregnancies, there is no evidence of an intrauterine pregnancy, by which we mean either a gestational sac with a yolk sac or a fetus inside of the uterus. Since you need to know whether you see one or not, a quick word on gestational sacs. There are true gestational sacs and pseudo-gestational sacs, so don't let the latter fool you. A true gestational sac will usually be located eccentrically within the uterus, which means not smack dab in the center. It may also exhibit something called the donut or double decidual sign, which appears as two concentric rings around the edge of the sac on ultrasound. These rings represent the layers of the decidual structure, or area of interface between mom and fetus. A pseudo-gestational sac is something that looks like a gestational sac on ultrasound. These appear as small fluid-filled intrauterine structures. Sound familiar? So pretty much they're just trying to confuse you. This structure appears as a result of the chemical changes triggered by pregnancy, intrauterine or not. However, compared to true gestational sacs, pseudosacs are centrally located and don't have the double decidual sign. Okay, glad we cleared that up. Moving on to more ultrasound findings you may see when you have an ectopic pregnancy. If on transvaginal ultrasound you see either a gestational sac plus yolk sac or a fetus anywhere outside of the uterine cavity, this is diagnostic of an ectopic pregnancy. However, it's more common to see a complex hypoechoic adnexal mass, symbolized by this ultrasound black Tamagotchi, remember those? Rather than clear evidence of an extrauterine pregnancy. While this finding is not diagnostic of an ectopic pregnancy, it can certainly raise your suspicion for one. Another feature that should push that complex hypoechoic adnexal mass into ectopic territory is if you see increased blood flow to the area on Doppler ultrasound. This is a special setting on the ultrasound machine that shows blood flow, and as we know, pregnancies are highly vascular. While you're ultrasounding, note if there's any intra-abdominal free fluid. This could be a sign that there's blood in the abdomen from a ruptured ectopic. Before we move on to the assessment and plan, let's quickly go over the differential diagnoses you should consider, which are the DDXs for vaginal bleeding in early pregnancy and abdominal pain in females. For a quick review, check out these DDX clipboards. For a deeper dive, head on over to our sketches on these topics. Okay, where were we? Now that you've collected all the information that you can, it's time to interpret it. So you have a patient with a positive beta HCG and lower abdominal pain. The big picture when trying to figure out whether or not she has an ectopic pregnancy is whether or not you can definitively say you have an extrauterine pregnancy or not. The easiest way to do this is by visualizing evidence of an intrauterine pregnancy on ultrasound. Conversely, if you see evidence of pregnancy outside of the uterus, then you have a confirmed ectopic pregnancy. But alas, life isn't always this easy. This is where the discriminatory zone comes in. The discriminatory zone is the beta HCG value at which you should be able to visualize a pregnancy on ultrasound. Traditionally, this number has been 2,000 milli-international units per milliliter, though the American College of Obstetricians and Gynecologists recommends using a higher threshold, 3,500 milli-international units per milliliter, to decrease the risk of interfering with a normal pregnancy. If you have a positive beta HCG and no IUP on ultrasound, the next piece of information you should note is whether or not your beta HCG level is above or below the discriminatory zone, which we'll go over the significance of more in a bit. But remember, these are all ectopic pregnancies until proven otherwise. Now we'll go over various scenarios that you could be faced with once a patient has a positive beta HCG and no intrauterine pregnancy seen on transvaginal ultrasound, and how to work each one up. Let's start with the nightmare scenario, a ruptured ectopic. We're reviewing it first because it's the scenario you want to be able to assess the quickest and the one you'll act on the fastest. All of the signs and symptoms that should make you suspicious for a ruptured ectopic reflect blood in the abdomen from the hemorrhaging site of rupture. Remember, pregnancies typically need a lot of blood flow to develop, so these sites are usually very vascular and can bleed liters of blood. The signs you want to look out for are hemodynamic instability on vitals or peritoneal signs on abdominal exam, which reflect fluid in the abdomen. If you see any of these signs, get in touch with the OR. They've got a case coming in. Now moving on to some slightly less hair-raising scenarios. In the following cases, the patient will be stable and the goal will be to assess whether she has an ectopic pregnancy or intrauterine pregnancy. Okay, so you've got a positive beta HCG and you're doing a transvaginal ultrasound, but you see nothing. You scan around to try and see if there's any evidence of an extrauterine pregnancy, but still nothing. What you've got on your hands here is a pregnancy of unknown location, often abbreviated as PUL, just like on the button this guy's wearing. It's exactly what it sounds like. You know your patient is pregnant from the positive beta HCG, represented by this guy's beta sunglasses, but you don't know where it is, represented by this broken ultrasound bullhorn. The first thing you're going to want to do if you find yourself in this situation is to assess whether or not you should be seeing an intrauterine pregnancy. You can figure this out by noting whether or not your beta HCG value is above or below the discriminatory zone. Remember the discriminatory zone? It's the value above which you should be able to visualize a pregnancy on ultrasound. Let's start with a scenario where your beta HCG value is below the discriminatory zone. So, you know that your patient is pregnant, but she's so early in her pregnancy that you shouldn't see a pregnancy yet on ultrasound. But she's complaining of abdominal pain and some vaginal spotting. This is when it's really important to have a conversation with your patient. Is this a desired pregnancy that, if normal, she would like to continue? If it's the beginning of an early pregnancy loss, what management routes is she open to? Does she need more time to think about it? Probably definitely this last one. It's a lot of information to take in. Also, since this pregnancy could still be an ectopic pregnancy, you must counsel her on the possibility of this as well as the possibility of rupture. Let's look at the scenario where she does desire this pregnancy and the beta HCG is below the discriminatory zone. Because this patient is stable, it's okay to wait to see if the pregnancy is developing normally and wait to see whether or not you can visualize an intrauterine pregnancy once her beta HCG is above the discriminatory zone. You'll do this by getting serial beta HCGs. This means you'll draw a new value every 48 hours until you have a definitive diagnosis. The beta HCG should roughly double every 48 hours up until around 10 weeks gestational age. In addition to looking for a normal rise in beta HCG, when the HCG value is above the discriminatory zone, you should check to see if you can visualize an intrauterine pregnancy on ultrasound. If the HCG value does double every 48 hours over a few checks, and then an intrauterine pregnancy is visualized once the HCG is above the discriminatory zone, then she most likely has a normal pregnancy and can continue on with standard prenatal care. If you start trending beta HCGs and they do not double every 48 hours, then you have some sort of abnormal pregnancy on your hands. Either an ectopic pregnancy or a pregnancy that will likely spontaneously abort because it isn't developing normally. If you have an abnormally rising beta HCG level, represented by this shorter stack of beta sunglasses, plus you see an adnexal mass on ultrasound, represented by this black Tamagotchi, you can assume that this is an ectopic and treat accordingly. More on that in a bit. If your beta HCG is abnormally rising and there is no adnexal mass, represented by this shorter stack of beta sunglasses with no Tamagotchi on top, you have a few options to discuss with your patient. Basically, you can either treat this as a non-viable pregnancy that will likely result in pregnancy loss, or you can treat it as an ectopic. The first option is to perform suction curettage, also known as dilation and curettage, or a DNC, which is why there's a curette mirror on top of this beta sunglasses rack. This option is both diagnostic and therapeutic. If the fetus is abnormally developing this early in the pregnancy, it's almost certain that it will result in a pregnancy loss, and performing a DNC will both evacuate the abnormal pregnancy and tell you definitively that the pregnancy was intrauterine and not an ectopic by checking for chorionic villi in the uterine aspirate. If there are chorionic villi, you can be sure that the pregnancy was intrauterine and not an ectopic. If that patient doesn't want to undergo a surgical procedure, another option is to treat this pregnancy as an unruptured small ectopic pregnancy. In this case, you can presumptively treat with methotrexate, represented with our recurring symbol, meat sticks. We'll go over this medical treatment for ectopic pregnancy in more depth in just a bit. Speaking of treatment, there are 3 broad categories: expectant management, medical management, and surgical management. Expectant management is letting the pregnancy run its course until it involutes. Because of the potential of ectopics to rupture, the risk of choosing this management path should be discussed in detail with the patient. For the same reason, the criteria for expectant management is fairly stringent. There should be no evidence of an extrauterine pregnancy on ultrasound, and the beta HCG should be less than 200 milli-international units per milliliter and decreasing. The other absolute requirement for expectant management is that the patient must have reliable follow-up. This means that they have a working phone number, stable transportation, and are willing to follow all instructions when it comes to returning to the lab to get their beta HCG trended down to 0. If while trending the patient's beta HCG you find that it's rising, you must move on to either medical or surgical management. For medical management, the folate antagonist, methotrexate, again represented by the meat sticks, is used. It inhibits DNA synthesis and will terminate the ectopic pregnancy. When choosing methotrexate, it's important to make sure the patient meets all of the eligibility criteria. These criteria are that the patient is hemodynamically stable and that they have a beta HCG less than or equal to 5,000 milli-international units per milliliter. There should also be no fetal heartbeat seen on ultrasound, and she has to have reliable follow-up. Some providers will use a size cutoff as a part of their inclusion criteria. This is not an absolute requirement, but know that the cutoff is usually 3.5 centimeters. As in, if the ectopic is less than 3.5 centimeters, the patient is eligible for methotrexate. The reason for all of these criteria is that if they're not met, studies have shown that the likelihood of treatment failure is higher. In addition to meeting the inclusion criteria, patients must also not have any medical contraindications to methotrexate. These are a ruptured ectopic pregnancy, evidence of renal or liver disease on labs, chronic lung disease, immunodeficiency, or actively breastfeeding. To ensure that the ectopic pregnancy has responded to methotrexate, serial beta HCG should be drawn until the value is 0. This usually happens between 2 and 4 weeks after methotrexate administration. If the patient does not meet the criteria for methotrexate treatment, this is when surgery should be considered. The main indication for surgical management is a suspected ruptured ectopic. We've made these scalpels unstable so that you're reminded that if your patient has unstable vital signs or signs of an acute abdomen, they should get emergency surgery. The other indication for surgical management is if the patient has failed methotrexate treatment, which is why we've put these scalpels next to this old failed meat stick. The two types of surgery you'll do to assess what's going on in the patient's abdomen are either an exploratory laparotomy, also known as an XLAP, or exploratory laparoscopy. The decision whether to perform open versus minimally invasive surgery depends on multiple factors, such as surgeon preference and patient body habitus. Once you're inside the abdomen and have visualized the ectopic pregnancy, there are two options. Either cut the fallopian tube and the ectopic out, called a salpingectomy, or just remove the ectopic pregnancy through making an opening in the tube, called a salpingostomy. If the ectopic is ruptured, you must perform a salpingectomy. A quick but very important note. When removing the fallopian tube, you should not remove the ovary. The ovary provides the oh-so-important estrogen for continued cardiac and bone health. It also contains your patient's eggs. If you remove the ovary, you'll compromise both overall health and future fertility. As with any time the maternal-fetal barrier is potentially breached, all Rh-negative women should receive anti-D immunoglobulin, also called RhoGAM, within 72 hours of the inciting event. The main complication of both medical and surgical management is treatment failure. This means there's residual chorionic and embryonal tissue, usually reflected by a beta HCG value that does not resolve to 0, or worse, begins to rise again. The options if either of these happen are to give another round of methotrexate or to proceed with surgical management, if that was not the initial form of treatment. Okay, so we learned a lot while reliving our past punk phase over here at Ectopic. Speaking of ectopic, today we learned about ectopic pregnancies, which are non-viable extrauterine pregnancies that most commonly implant in the fallopian tube, specifically the ampulla. The most common chief complaints are first trimester vaginal bleeding and lower abdominal pain and pelvic pain that happens around 8 weeks after the patient's LMP. Those at the highest risk of having an ectopic pregnancy are those with a history of an ectopic, PID, scarred tubes, and those who have had IVF or have gotten pregnant with an IUD in place. Ruptured ectopics are the most concerning complication, as they can lead to massive hemorrhage and even death if left untreated. You should be concerned for a ruptured ectopic if your patient is hemodynamically unstable and/or she has any peritoneal signs on abdominal exam. In terms of an assessment, the two most important studies to get are a beta HCG level and a transvaginal ultrasound. You'll be concerned for an ectopic pregnancy if you have a positive beta HCG level but no intrauterine pregnancy seen on transvaginal ultrasound. If the transvaginal ultrasound shows a pregnancy outside of the uterus, then this is a definitive diagnosis of an ectopic pregnancy. If you have a positive beta HCG level and can't see a pregnancy anywhere in the abdomen, this is called the pregnancy of unknown location, or PUL. If you have a PUL, the first thing to note is whether or not your beta HCG level is above or below the discriminatory zone, which is usually set around 2,000 milli-international units per milliliter. If the beta HCG level is below the discriminatory zone and the patient is stable, you'll want to trend it every 48 hours for two reasons: to see if it's rising appropriately and to see if you can visualize an IUP once it's above the discriminatory zone. If your beta HCG trend is showing an abnormal rise plus a complex adnexal mass on ultrasound, you most likely have an ectopic, so you'll treat it as such. If your beta HCG trend is showing an abnormal rise but no complex adnexal mass on ultrasound, you can do a diagnostic and therapeutic DNC or treat with methotrexate if appropriate. The idea here is that this pregnancy is abnormal in some way and is either intrauterine and needs to be removed, or is an ectopic, which should resolve with methotrexate. When you've decided, hey, I think my patient has an ectopic pregnancy, you have three treatment options: expectant, medical, or surgical management. Expectant management has very stringent criteria, such as no masses on ultrasound, a very low beta HCG of less than 200 that's declining, and good follow-up. Methotrexate is used if the patient is stable, has an HCG less than 5,000, no fetal heart rate, and good follow-up. Some providers also want the ectopic pregnancy to measure less than 3.5 centimeters. And finally, surgical management is for those patients who are hemodynamically unstable and are showing peritoneal signs, both of which are concerning for a ruptured ectopic, and those who have failed medical management with methotrexate. Those cords sure take me back. I'd say this lesson was worth the trip to the mall, wouldn't you? Now, if you'll excuse me, I have some pits to mosh in and crowds to serve. Till next time, kids.